Good evening, everyone. Good evening to one and everyone present here. I'm Bhumika, a national officer from PD Wing. Welcome you all to case history discussion and endodontic perspective. Today we have with us Dr. Nemath. He is an intern from GDC Mumbai. He has done a major recent achievements, which include he has published a paper in international journal and also won a second prize in a special paper presentation at International College of Dental College, and also he has been an endodontic subject topper. He's also been nominated for 𝘱𝘱𝑓ouchard International Student Academic Award for 2021. We welcome you, sir. The floor is for you.
Thank you so much, Mika, for this wonderful introduction. And I'm really honored and thankful for this opportunity. I mean, being an intern to take a lecture for all of you, it's a very big thing for me. And I'll try to be very genuine and make you understand the concept very well as per your knowledge. And it will be an interactive session. I'll be having some questions for you. You have to answer in the chat section. No need to pop out from your mic to say something. And I know tomorrow is Monday, so everyone is little bit reluctant कि कितना देर तक चलेगा lecture and all. But I'll try to do the best. So just stay where you are. Take your pens, notebooks. It will be totally based on practically, not theoretically much. And that too, I'll consider the practical scenario of a college, not the ideal situations what we see in the textbook, but how to deal with these cases and all these diagnosis and everything related to endodontics and your case histories that you present during your examination in front of the teachers or your external examiners. So that is much more important. And my aim for this session is to keep this very simple and brief you about the basics of the endodontic case histories and the diagnosis. So we'll start with it. I've made a presentation for you all. I hope you will like it. Am I audible?
Yes, you're audible.
Okay. If you have any doubts, you can just put in the chat section. We can discuss it later after the lecture gets over. Can you see my screen?
Yeah, we can see.
Okay. So as the topic says, clinical discussion, case history with an endodontic perspective. So before we move ahead, I like to brief you about what is case history as per se. So in this session, I'll be covering 4 topics, like what is a case history, the objectives of case history, and how to take a case history in the endodontic perspective. There will be a sample case history also at the end, which will be focusing on irreversible pulpitis. So first of all the examiners, they start your case history by asking you, what is case history? So we have so many definitions, can be a conversation, it can be a professional conversation, many things, but how to put it into a particular word so that you can obtain a particular, and definition for this. So case history is defined as a planned professional conversation that enables the patient to communicate his or her symptoms, feelings, and fears to the clinician so as to obtain an insight into the nature of the patient illness and his or her attitude towards them, and procure a well-oriented treatment plan on the basis of the same. So case history basically is a type of conversation between a doctor and a patient. The patient comes to you with the hope that someone will understand his pain and suffering. So the hope he has in us is can be only showed how well you can ask him about his problem. So अगर आप देखोगे यहाँ पे केस हिस्ट्री एक planned professional conversation है दो लोगों के बीच में. It should be planned because in dentistry the case history is not just a health interview questionnaire or a normal interview. Basically it is a combination of both. You're also asking him the personal information about him in a planned format. You're not just asking him randomly anything like, what is your problem, what is the thing. You have to keep the professional mindset inside you, and show yourself as a doctor. So as the definition says, it's a planned professional conversation. And it's very important to obtain an insight into the nature of patient's illness. You have to frame the question such that you need to take out answers from the patient's own mind. And all the answers should be in his own words. You don't have to confuse the patient. You have to ask such questions that the patient itself will lead you to a particular diagnosis. The case history should not be in the way that you are asking some particular questions, he is answering in a different way. And the major goal of taking case history will be ruined. जब तक वो क्वेश्चन जो तुम्हें पूछ रहे हैं, जो उसकी तकलीफ है, अगर वो ही हमें वो बताएंगे तो बेटर रहेगा, not you guiding him to tell something different. So that can lead to a very different diagnosis, which will eventually lead to a different treatment plan. So that is a loss of you as well as the patient. Now, what are the objectives of case history? First of all, to establish a positive professional relationship between you and the patient, and to provide the clinician with the information concerning the patient's past dental and medical and personal history, and to provide the clinician with the information that may be necessary for making a diagnosis, to provide information that aids the clinician in making decisions concerning the treatment of the patient. So these are the basic objectives of a case history. First of all, to maintain a relationship between you and the patient. As you know, in dentistry, our cases are not that you will just come and take a diagnosis and give them the medicines and let them to go. It is a stepwise process. All the treatment requires certain steps. So you have to maintain a trust, a relationship with the patient. To achieve that, your way of taking case history should be very professional. Should be very, you have to go through the depth of the patient's feeling. So that will help you to establish a positive professional relationship. And secondly, the major aspect of taking case history is to gather all the information. It can be patient's past dental history, medical history, personal history, all kinds of histories, so that it can lead you to a best diagnosis for that particular case. And again, it can be also additional information. Investigations are required, certain examinations are required, certain examinations हो गए, investigations हो गए, report हो गए, differential diagnosis हो गया. So there are many things which a case history can give you. So these are the major objectives that are provided from the case history. Now, as well, I was saying you, what is the dentist method of taking a case history? So it is a combined method. The combined method is considered by the authors to be the best appropriate technique for history taking in the routine practice of dentistry. This approach uses advantages of both the techniques. If you take a chapter of case history, they are divided into various sections. So ideally, they divide case history into 3 types. It can be an interview questionnaire, health questionnaire, and the combination. But we as a dentist, we apply both of them. So in interview, what we do is we ask the patient about his or her health in an organized fashion. The patient is allowed to discuss any problem fully. But in the second phase, we ask him the health questions. The health questionnaire is a printed list of health-related questions that the patient is requested to answer at the first appointment. You guys are having your journals. In journals, you will see that there's a printed version of case history. So that questions which are asked, like chief complaint, history of present illness, all the past dental history, medical history, everything, these histories comes under the health questionnaire. The interview is the form of question that you are asking. So it depends totally on your way of taking the case history. You should be very thorough with the language and the language which patient is comfortable. I mean, आपको बहुत अच्छी इंग्लिश आती होगी, लेकिन पेशेंट मराठी में बात करता है, तो it cannot be deal like that. You have to use any kind of language to address the patient and ask him all his illness symptoms to arrive at diagnosis. Now, how to take a case history? These are the list of details how a case history minimum should have. First of all is to assemble all the facts such as the personal information of the patient, like name, sex, age, marital status, address, religion, education, income, occupation, phone number. It's very important because the name of the patient helps you to address him, and If someone calls you by name and that to a doctor, the patient then and there itself feels like this doctor can understand me. He's calling me by his name, by his own name. So that's why name is very important. And also to maintain the records for medical legal cases. Sex is important because there are certain gender predilection of diseases which can be ruled out. Age also is very important. Certain diseases are, seen in particular ages, like hypertension, diabetes and all is in older age people. Nowadays the trends are different because of lifestyle. Even the young people are having diabetes, but that's a different thing. And marital state is also important. Then age is also important for ruling out the drugs, the doses of the drugs. Address is important because you will know where the epidemic cases are and what are the general cases occurring in that particular area. It can be like in Mumbai, Sayan and Dhara is very epidemic for TB cases. And in Rajasthan, you can see fluorosis is very prominent over there because of the water supply over there. They contain lots of fluorine. So the address is also very important. Education status is important because you have to at first judge the patient with what level the literacy he has. If he's very literate, he has done MBA and all, if he's very graduated, you have to ask the questions in that way. The patient also will expect much more from you. You have heard these days there are patients known as Google patients. These are the patients, they diagnose themselves first and they come to the clinic and then it's basically not they come for their treatment, but to counter you with all those facts that he has learned. So to tackle those patients also, we have to take the education status and start a case history with that scenario. So this all personal information is very important. Then next comes the chief complaint. Chief complaint is what the patient gives by his own words. Like suppose a 32-year-old male patient came and is telling, "Sir, मेरे ये बाजू में बहुत दुख रहा है दांत." So this has to be written in his own word. You cannot add any professional tags because the reason you have been listening to this by teachers that the patient के खुद के own words में लिखो chief complaint, and they don't tell you the reason why. It's because this case history is not specifically for your clinic or for your own concern. Suppose if you are passing down the patient to some other doctors or to other dentists, so this case history, when they go, the patient is not going along with it. The only case history is being presented to the other clinician. At that particular time, if you say some technical words, it's obvious that the patient won't be knowing those words to tell, मेरे राइट मैंडिबल में बहुत दुख रहा है, ऐसा कोई नहीं बोलता. Patient will just say कि मेरे ये बाजू में या उस साइड पे उस दांत में दुख रहा है. So the other clinician, the other doctor can understand it very well. And if you add any professional tag in that chief complaint, it can lead to some other thing. If the patient is telling, because the chief complaint, when he's speaking, you're not looking the patient intraorally. So if you write directly, if the patient is complaining of pain in lower right mandible, in the tooth and all, so it can be like pain tooth में नहीं होगा, mandible की bone में होगा, gingiva में होगा, तो वो deviate करता है तुम्हें अगर तुम professional words डालते हो. The chief complaint should be in its own words. Then comes the history of the present condition and illness. यहाँ पे if you see exam point of view, the examiner only sees three things. How is your chief complaint written and how is your history of present condition illness is written. यहाँ पे पूरी कहानी लिखनी होती. पेशेंट को जब फर्स्ट टाइम पेन हुआ था तो अभी आपके क्लिनिक में आने के बाद उसका क्या स्टेटस है उस पेन का, वो पूरी हिस्ट्री लिखनी होती है. इट कैन बी विथ एनी कंडीशन, लाइक एनी लेंथ ऑफ द वर्ड्स. You can write a paragraph, you can write a story, but history of the present illness is the major and most important aspect of case history. You have to write it in a brief way. You have to ask patient everything. When was the first time he experienced that pain? When was the first time and how was the type of pain? What is its onset, duration, progress, aggravating factors, relieving factors? Everything is to be written in this history of present illness and condition. Then comes the dental history. I guess everyone is listening, right? Because I'm just speaking here, no one is responding with anything.
Yes, so we're listening.
Okay, thank you. So yeah, this is the history of the present condition illness to be written like that. Then comes the dental history. Now, dental history. Hello. Yeah. So dental history is why important, because dental history can give you the experience of the patient. If he has any past dental history, this particular patient can, he can judge the patient. What was the treatment like when he had went to some other dentist? What was his experience? Was it bad or good? Suppose if he had a very bad experience in the past, obviously he'll be very nervous when he comes to you, and he will be expecting like ये dentist भी ऐसे ही निकलेगा, मेरे को ऐसे दर्द देगा ये भी dentist, ऐसे वो इमोशनल हो जाता है. या फिर किसी का बहुत अच्छा हुआ होगा एक्सपीरियंस, हम तुमने कुछ गलत किया तो तुम पे वो बोलेगा ऐसे. इट्स लाइक अ फैक्टर फॉर यू, फॉर योर प्रोफेशनलिज्म टू जज. So dental history is not only important to judge your professionalism, but also to know what was the treatment aspect given before, what all treatment he has gone through. Like पहले कभी इसने local anesthesia लिया होगा, तुम्हें मालूम पड़ेगा. Like he is given history of extraction, so you will be knowing कि नहीं इसका extraction हुआ है इतने early age में, मतलब इसका dental hygiene उतना अच्छा नहीं रहेगा. You can judge the patient with dental history. He has multiple crowns, then you will be knowing his oral hygiene is not maintained, or maybe he is a patient who wants to save all the teeth, but still he does not maintain any oral hygiene. That's why he has so many crowns and prostheses. So as a dental history can explain you the patient's judgment about his illness. And if he has no experience, then it's a boon for you, because you can be really good to him, you can showcase your skills very nicely, and take the patient in your hand for all the cases in future if it's your private clinic. But ठीक है, गवर्नमेंट में हम लोग काम करते हैं, we chase the postings and all, so it depends. And medical history is the next. Medical history में भी सब कुछ पूछना होता है. It can be diabetes, hypertension, cardiovascular diseases, tuberculosis, epilepsy, allergy, bleeding disorders, medications, allergy to medications. And if the female patients is there, then you can ask about the menstrual irregularities, pregnancy, anything like that, because this will help you to judge his, you can formulate your treatment plan. If the patient is diabetic, you cannot just advise him extraction straight away. Or if the patient is hypertensive, you cannot inject him LA because he will be already in beta blockers drugs. So that all things has to be ruled out. That's how we take the medical history. Family history as such in dentistry is only related if he has particular severe medical history. Like if the patient is having diabetes or hypertension, it might be follow his lineage from the family history. But per se, dentistry, the family history is not so important, but we have to ask. It can be like if the patient's child is having so many caries, he has come to you with this child, you'll be expecting कि इसके father को भी dental hygiene अच्छा नहीं रहेगा, because if the child is suffering with so much of caries and so much of dental issues, it's obvious that the parent is not aware of the dental practices, how to maintain this oral hygiene. So there you can, family history comes to be very important. Then comes the personal history. Personal history can be divided into two parts. It can be habits which he practices, and also about the hygiene what he practices. Now, like oral hygiene habit, and clean, he has any habit of clenching or bruxism, like that, or he has any habit of anxiety, tension, or nervousness. This also comes in under habits. And other habits like alcohol, cigarette, tobacco chewing, pan chewing, this also can be ruled out. You can expect the patient's hygiene is very bad if he is having all those kinds of habits. And certain drugs are contraindicated if the patient is alcoholic. So that helps you to rule out. Then comes the examination. And today, as we are discussing the endodontic case, I won't be going very deep in examination of journal body and journal oral examination. We'll be discussing detailed about the endodontic examination. So in journal body examination, you have to look about his build, skin, gait, nails, conjunctiva, sclera, everything. And oral examination can be divided into two parts, extra and intraoral. Extraoral, you have again facial symmetry, lips, TMJ, lymph nodes, and any other abnormality, if we can see the profile of the patient. And intraorally, you have so much to see inside. The number of teeth, soft tissues, tongue, cheek. In tongue also, you have to see the papilla, the coating, the movements of the tongue. Any lesions are there or not. Sometimes the patient comes, with a sharp cusps and broken or fractured tooth, which impinge on the soft tissues. They can also, make you help to achieve a certain diagnosis. Then you have cheek. Buccal mucosa can reveal enough number of secrets of the patient, whether he is diabetic, whether he is alcoholic, whether he is having any medical condition. Your entire oral mucosa is a gateway for seeing the patient's whatever is going through. Even if the patient is lying, the oral mucosa won't lie. So oral mucosa is very important to check. Then comes the floor of the mouth, all the Wharton's duct, Senson's duct, lingual varicosities, where we have to just mention the gingiva condition, the dentillous ridge, or anything if it is present. After all this, we have detailed examination of the area of chief complaint, which is the most important part to achieve a complete final diagnosis. Then after that, we just see everything of the chief complaint, and then comes to the proposal diagnosis and differential diagnosis. Then we'll give him the investigations like blood, X-ray. X-ray where you have RVG, IOPA, serology, biopsy if it requires. And even in examination, in oral, we have, if swelling is present, we have to examine the swelling, which comes under inspection, the palpation. In the palpation, we see about the local temperature, tenderness, and everything. Then we achieve at the final diagnosis. Then we formulate a treatment plan. Moving on to the case history of endodontic. Before that, I wanted to explain you this classification of all the pulpal diseases. I have taken all my this notes and PPT from Grossman and Engel. So the Grossman have beautifully given the classification of the pulp. Before, we used to categorize the inflammatory diseases as acute and chronic, but they have changed this because it's not giving a particular name to it. Acute, they don't have any specific amount of time, how much time it's acute or how much time it's chronic. So they have divided into major group as reversible pulpitis and irreversible pulpitis. And the irreversible pulpitis have been further divided into many sections like symptomatic irreversible pulpitis, which was previously known as acute irreversible pulpitis. Then comes the asymptomatic irreversible pulpitis, also known as the chronic irreversible pulpitis. In chronic hypoplastic pulpitis, internal resorption. Then we have pulpal degeneration diseases like calcific degeneration. Calcific degeneration can be only seen in radiographic diagnosis because other diagnosis can be seen clinically. But calcific degeneration, they don't have any particular symptom until unless you have any other lesions, so it can come out in the radiograph. And then there we can diagnose it. Then fibrous degeneration, pulpal necrosis. So this is the clinical classification of the pulpal diseases. Now, if you see the clinical classification over here, you can differentiate the classification was given earlier. So what do you expect by looking at the teeth? Now, if you see in A, B, and C, these teeth have minor caries. I'm not telling that by just looking, you can say they are minor caries or they cannot have any pulpal disease. But by inspecting, you can rule out that the A, B, and C diagram may have reversible pulpitis condition or hypersensitivity condition. You can rule out that thing. But if you look at the figure D, E, and F, you can see the tooth is not almost, completely gone. You can see that. You have deep carious lesions, broken tooth, almost the crown is fractured, nothing is left. So by inspecting this scenario, you can rule out कि भाई इसको ये disease हो सकता है directly, not necessary to go further. Now you can see the diagram C. Have many very only surface caries is present, and there can be a minor deep caries inside the tooth. But you can rule out the treatment plan for this as soon as you give a look. But D, E, and F, you have to judge with everything. You have to do all the testing. You have to do every kind of examination over the teeth. So by inspecting these kind of teeth, you can, make a provisional diagnosis in your mind. Now, this is a one more case known as chronic hyperplastic pulpitis. It's also called as pulp polyp, which can be an overgrowth of pulp tissue outside the boundary of pulp chamber. Now, this is seen only in deciduous molar and first permanent molar, because the young, when the teeth is young and there are lots of pulpal tissue inside, the response to the external forces is not very severe. It's a very gradual response, and over the time, the pulp just reacts and heals and react. Minor inflammatory changes, minor healing changes, which can lead to this pulp polyp, and it comes under asymptomatic irreversible pulpitis only. And the pulp polyp grows because of the changes inside the oral cavity. Constant trauma to the pulp can lead to chronic hypoplastic pulpitis. So I have a question for the audience over here. Now, can you see my cursor over here? Anyone can speak. It's okay.
Yes, sir.
Yeah. So this is the pulp polyp you can see over here. And if you see this diagram, can you rule out what is this? Anyone can answer this question.
Gingival polyp.
Yeah. So this is a gingival polyp. Now, how will you differentiate between both? Now, just inspecting, if you can see here in this first diagram, the pulp polyp is always centralized to it. It is not at the proximal sides or at the very facial side. It's always centrally placed. And whereas the gingival polyp, you can see this always in class 2 cavities. Now, if you have done the class 2 cavities, you'll be knowing that this is the most irritating thing when you do a class 2 cavity. The gingival polyp always comes in the between, and even if you cut the gingival polyp and don't cover it with proper restorative material, this can again regrow. So to differentiate between the gingival polyp and the pulp polyp, you have to use a probe. You have to place the probe in the proximal side and check whether where the stalk is leading to. If the stalk is leading to the gingival, there is a gingival polyp, and if the stalk is leading inside the pulp chamber, that's a pulp polyp. It's a very important thing, because most of the class 2 cavities who have severe pulpal pain, you have to rule out it, because if it's a chronic hypoplastic pulpitis, your entire treatment plan is different, and if it's a proper gingival polyp, your treatment plan may differ. Now, if you see that how the pulp is reacting, it can be, it depends on the immunity of the patient. Now, if you see particular here, the normal pulp can change to reversible pulpitis and can go back to normal pulp depending on the patient's hygiene, patient's condition, and patient's immunity. If the patient is not maintaining his oral hygiene and the cavity is progressing, it can lead to a permanent damage known as irreversible pulpitis. Now, irreversible pulpitis can take many phases depending again on the immunity, the oral hygiene, and the amount of cavity inside the patient's mouth, the depth of caries inside the patient's mouth. So it can be divided into chronic hyperplastic pulpitis if a young patient is there. Irreversible pulpitis can be symptomatic, can be asymptomatic, and can lead to internal resorption also. And these all phases of the irreversible pulpitis, if it's not treated in a particular time, can go into a symptomatic stage, leading to proper pulpal damage known as pulpal necrosis. Due to certain immunological factors or any degenerative changes, can lead to calcific degeneration and metamorphosis. And if there's a trauma, direct blunt hit, or you can say, if you're doing some class 2 cavities and you're not aware that you're going much more deeper than the stipulated depth it's given for you, like 2.5 mm, you have to go deep, but you went more deeper inside, and then you didn't use your proper water or any syringe or airway to desiccate the debris. It can lead to ischemia, leading again to pulpal necrosis if not treated in the time being. So now this does not only lead to pulpal inflammation, only the boundaries to the pulpal chamber, but if it's not looked after very quickly, the pulpal inflammation can convert into necrosis, and the infection can traverse beyond the apical foramen. It can lead to symptomatic apical periodontitis or asymptomatic apical periodontitis. It can, further lead to any kind of lesions given here. So these all lesions depends again on the immunity of the patient and his oral hygiene, and as well as how the caries is progressing inside it. If there's a female, then hormonal also plays a very important role. So this is the sequelae of further pulpal infection beyond the apical foramen. Now this is what it looks like. On the right side is the inflamed pulp tissue. The inflamed pulp tissue can go to pulp chamber to the root canals to the inflamed ligament. Now, if this lesion stays there for a much amount of time, the inflamed pulp, if not treated by root canal treatment or by any restorative treatment, it can lead to infection of the pulp. Once the pulp gets infected, it will lead to necrosis. The necrosis will clog entire pulp inside. There will be no circulation. There will be no flow of nutrients. The microbial activity will be very much, and the microbes will start to expand. Once they start to expand, they don't have any area to move but downwards. They'll move towards the apical foramen and leak throughout the apical foramen into the periradicular tissues, leading to abscess. So this is how the disease progress inside. The endodontical disease can progress. So whenever a patient comes to you with a minor cavity or any kind of cavity which is not so deep or not so progressive, you have to explain the patient. In India, the major issue of dentistry is that people are not aware. They think teeth as don't even think about the teeth. It's we who are very cautious because we have entered in dentistry. Otherwise, honestly, if I asked you, you won't be able to take care of your own teeth at this age so much. You have seen very young patients coming with so much of 20 to 21 patients are going for extractions of molars at too. So this also because of the neglect and no awareness among the individuals of our citizens. It's very important to explain them. So as soon as the disease progresses to the apical foramen, we have a number of periodicular diseases which is stipulated inside this table. Now you can see there can be symptomatic periodicular diseases like symptomatic apical periodontitis. It can be acute alveolar abscess, acute exacerbation of asymptomatic apical periodontitis. Whoever is in third year right now, they must be having a little bit of confusion what sir is saying, but you will get to know once you read this chapter very nicely. Right now, just keep in mind that any kind of infection, inflammation, if it goes beyond the pulp, it can lead to periodicular diseases. So this is the classification. We have symptomatic, asymptomatic, again symptomatic divided into 3 parts, asymptomatic also divided into 3 parts. Then can be external tooth resorption, persistent apical periodontitis. Apical periodontitis can also be due to malocclusion scenario, but as we are dealing through endodontic aspect, this is how it progresses from pulpal inflammation to periodicular inflammation. Now let's come to the major topic of the day. What is a case history and how I am going to explain the endodontic perspective. So as I said, just teeth complaint is an important topic. It has to be in patient's own words. It has to be taken in a chronological order. It has to be as descriptive as possible. And you can see in this diagram, sometimes the patient comes, with a pain and, discomfort when he doesn't know where the discomfort is coming from. So that makes you, think, ab main kya likhu isme ye complaint. So you don't have to worry about it. He's pointing out the direction, the side. You just have to mention the side in the chief complaint. After that, in history of presenting illness, you can ask him brief questions. Now, history of presenting condition or illness is a very important topic of the case history. First of all, we have to ask the patient what is the onset. When did the pain start? Then we have to see the location. If it's a very sharp and easy to locate the pain, it can be endodontically related. If it's a very dull pain and gnawing pain, it can be related to perio. Generally, periodontal diseases cannot be, easily located by the patient. He will just tell you, he just point out you at the region कि मेरे को ये तीनों चारों दांत में दुख रहा है. For that, you can rule out he maybe he must be having a periodontal pain along with an endo pain. Then comes the duration. Duration has many aspects. It can be for a short time, then suddenly it can increase to the long duration time. Sometimes the pain goes off for 3-4 months and again starts. So this also you have to ask. Then character is very important to rule out the pulpal pain. If it's sharp pain, shooting pain, dull throbbing pain, so it can rule out into either endo or perio. Even endo conditions have some gnawing and throbbing pain also. Then after that, you have to ask him the aggravating factors, the factors which increases the pain. You don't have to ask anything randomly, but once you get to know what is the onset, location, duration, and the character, on that basis, you have to ask the aggravating factors. Sometimes, in chief complaint only, the patient says, "Sir, मेरे को यहाँ पे ऊपर साइड पे कुछ गर्म खाता हो तो बहुत दुखता है, कुछ ठंडा पीता हो तो बहुत झंझनाहट होती है." So you'll get to know from this aspect उसका aggravating factor क्या है. But still, you have to ask the patient what is the aggravating factors. It can be, eating anything sweet, eating anything cold, hot, or biting. किसी किसी को ड्राई फ्रूट खाने पे बहुत दुखता है. Can suspect to minor fractures in the tooth. And also it's very important to ask the relieving factors. So, relieving factors is very important because again it can help you to rule out whether the pulpal pain is reversible or irreversible. When the pain goes off without doing anything, like a stimulus is provided, after short duration, when the stimulus is removed, the pain goes on its own. So it can be a reversible pulpitis. If the pain still lingers after that for a particular amount of time, or it is spontaneous sometimes and cannot be relieved because of any other things, but has to take the medicine, then it can be ruled out to irreversible pulpitis. And also you have to ask the timing and the severity. Like for how long does that particular pain last? Because perio pain usually stays for a variable duration without any stimulus. Even if you breathe air, sensitivity can be felt. If you are suffering from hypersensitivity condition, if you are just clenching your jaw, you can feel pain in your molars, can be related to periodontal pain. Now these are the examples which I have made. Like this is the part where all the teachers ask you the most of the questions, and until unless this part is not correct, not approved, your case history won't be approved at all. So short examples for the history of presenting illness for reversible pulpitis and irreversible pulpitis cases. You can take a screenshot also for this or your future journal writing. Now you can see the example of in the cases of reversible pulpitis cases. I have written it as patient was apparently all right 1 month back. Duration can be anything according to the patient's complaint. And he or she first, we have to start the HOPI from the time when he has first experienced that pain. The history of all kinds of his symptoms from the start. So we have to write the first experienced pain on chewing food in lower right back region of jaw. The pain was sudden in onset, short in duration, sharp and shooting in nature. It lasted for a few seconds. Hence, acute in progression, aggravates while having cold drink or food, and on having anything sweet. And pain is relieved on its own. Now, if you have read your Grossman and seen the section of reversible pulpitis, the symptoms which they have told to look out for are what? That the reversible pulpitis cases, they are sudden in onset. As soon as the stimulus is given, they have a sharp shooting pain. It's a piercing pain. It can be a piercing pain, but generally it's sharp and shooting of very short duration. So you have to ask such questions. Like if I am a clinician, I'm asking a case history, what will be my question will be? कि आपको कब से पेन था? Patient will tell 1 month back. तो ठीक है, फर्स्ट टाइम आपने कब एक्सपीरियंस किया, कैसा था? तो नहीं सर, बहुत जल्दी स्टार्ट हुआ, मैं कुछ खा रहा था, मैंने जैसे वो चबाया, पेन स्टार्ट हो गया। मैंने, कब तक था आपको पेन? जैसे ही मैंने खाना बंद कर दिया या फिर वो मैंने अवॉइड किया, वो पेन रुक गया। ठीक है, फिर हमने पूछा कि कैसे बढ़ता है पेन, कुछ पर्टिकुलर चीज़ से बढ़ता है क्या पेन? तो पेशेंट से कि नहीं, मैं जब कोई ठंडा पीता हूँ, ठंडा पानी पीता हूँ तो पेन स्टार्ट होता है। तो फिर हमें क्वेश्चन पूछना, उसको काउंटर क्वेश्चन पूछना पड़ता है कि नॉर्मल पानी पीने से भी दुखता है क्या आपको? तो ही आंसर दैट वे। एंड नाउ रिवर्सिबल का कैरेक्टरिस्टिक है कि it lasts for very few seconds and it can aggravate on having cold or sweet. Sweet is an important factor. The sweet suddenly changes the acidic environment of the oral cavity, and this acidity effect on the dentinal tubules very severely, leading to stimulation of the A delta fibers. You have, I guess we have read this in dental histology, A delta fibers and C fibers. So reversible pulpitis acts on the A delta fibers, which gives a immediate response of the pain. And the most important point is the pain is relieved on its own. So that is the characteristic of reversible pulpitis. Then the second part is the example of irreversible pulpitis. This is for the symptomatic case. So here the case history, the history of what is presented is it is as patient was apparently all right 1 month back when he or she first experienced severe pain while sleeping. Now, irreversible pulpitis can be of many causes. Now, the particular cause is sleeping. Nocturnal pain is a characteristic of irreversible pulpitis. If the patient tells you कि मेरे को रात में सोते वक्त दुखता है या फिर झुकने में दुखता है इस दांत में, he will point out to that pain directly कि मेरे को रात में अचानक जब मैं सो रहा हूँ तो पेन स्टार्ट हो जाता है. The particular feature of our irreversible pulpitis. So the case history is presented as severe pain while sleeping, chewing, even at talking, drinking tea. Now, drinking tea is definitely a hot tea, not iced tea. But hot, pain while eating anything hot is a characteristic of irreversible pulpitis. Now comes to the onset. The pain was spontaneous in an onset, lasted for a duration, continuous or intermittent in progression. I have put a slash over there because the patient can tell कि pain continuous था या रुक के था, intermittent in progression. Piercing, gnawing, and lancinating. Lancinating is like if you get hit with a ball over your leg, the pain radiates for a particular amount of time. It shows a radiation type of effect. So the irreversible pulpitis, they have a lancinating type of nature. Shorting in the sense means that even a slight change in the oral cavity can lead to very terrible pain. Shooting is a kind of progressive pain. And the pain aggravates on taking any type of food or drink, whether it be hot and cold, any type of food or drink can lead to irreversible pain. You can also ask the question कि दांत में कुछ खाना फंसता है क्या, निकलता नहीं है खाना फंसने के बाद, but can suspect of a deep cavity. Then it also aggravates on chewing and biting. It's probably because if there's a food lodgement in the deep cavity and the patient is biting, it is irritating its pulpal floor. And the particular feature is nocturnal pain is evident. This is the characteristic of irreversible pulpitis cases, even the postural pain. And one more thing is that irreversible pulpitis in the long-term cases can lead to referred pain. And also to the extent that the patient can experience this pain on the contralateral side also. It's a psychological pain, but it's in very rare cases. But in irreversible pulpitis, you have adjacent tissue pain also. You can refer to your head, adjacent bone. The patient will tell कि मेरे को पूरा सर से लेके नीचे तक दुख रहा है. And if you judge the patient's behavior, it does not come under HOPI, but under general examination. But if you judge the patient, irreversible cases, the patient himself or herself will be very restless. He'll be begging you, मेरे को treatment करो, मेरे को बहुत दुख रहा है, कुछ तो करो, like सोने नहीं देता, खाने नहीं देता. So that is also a thing to catch. ये reversible case है, reversible case है. But reversible patient will be like, हाँ कभी कभी दुखता है, कभी खाने पे दुखता है, कभी ऐसे बोलने पे दुखता है, ठंडा पानी पे दुखता है. You can also judge the patient from his behavior. Now, these are the basic HOPI for reversible and irreversible pulpitis. If any above symptoms are accompanied with pain and tenderness of a tooth on biting or chewing, intraoral swelling, pus discharge, sinus tract, fever, headache, any external swelling, mobility of tooth, then in these cases you can suspect, along with pulpitis cases, also 𝘱𝘱𝘙𝑜𝑟𝑎𝑑𝑐ular lesions. Okay. I hope I have done justice to explain this part, because it's very important in your postings. Now comes the detailed examination area of the chief complaint. What do you have to look in the chief complaint? First of all, you have to inspect the tooth. You have to see, is there any kind of discoloration? Because discoloration can give you many answers. And if the patient is dull looking or is reddish looking, so can suspect of necrosis. If it is pinkish looking, can suspect of trauma. If the luster is gone, yellowish in color, can lead to fracture. Then you have to also inspect the type of caries which is seen on the surfaces. Then comes the caries. You have to determine as we are as an endodontist or a dentist, we have to look for caries very thoroughly. Whether it be arrested or fresh caries, you have to assess it very thoroughly with explorer and a probe. You have to determine the form, the surfaces involved, and if it's a deep cavity, you have to probe the depth. Take a Williams probe or explorer, you have to probe it till the pulpal floor. So it is very important for that. Then comes the percussion. Percussion is you cannot say that a very important step that will rule out something for you, but it's very important because it can rule out the difference between the pulpal pain and the 𝘱𝘱𝑎𝑑𝑐ular pain. In cases of vertical percussion, you can suspect of apical periodontitis, as the periodontal fibers are arranged obliquely from all the sides. If you percuss the tooth from the above, like a vertical percussion, if the patient is having pain, you can suspect of any apical lesion, periapical lesion. And this vertical percussion is done on the cusp of the teeth, almost holding the probe in a perpendicular fashion. Then comes the lateral percussion. Lateral percussion can stimulate the pulp chamber inside, which can give you very immense pain, can tell you the status of the pulp, is hyper responsive or not. Sometimes the patient comes with, he or she tells you कि मेरे को बहुत दुखता है खाना खाने पे या फिर पानी पीने पे, and when you percuss that tooth, you are feeling nothing. So, and sometimes the patient comes with no pain. He just comes because there's a deep cavity. But as soon as you do a little percussion, you're having immense amount of pain, which lingers for a particular amount of time. So the second scenario, which I told you right now, can be irreversible pulpitis cases, and the first scenario can be hypersensitivity cases. In hypersensitivity, how much you percuss, you won't have any pain because there will be no stimulation of dentinal tubules. Then you have to check for the exposure. Now, this exposure is related to pulpal exposure. Like if you see the tooth is discolored, caries is very deep, percussion में भी उतना pain नहीं हो रहा है. You have to use a explorer and go inside the depth of the cavity. The patient will have a certain amount of pain as soon as you reach the pulpal floor. So you can suspect an pulp horn exposure or pulp chamber is exposed due to deep caries. Then after that it comes the pockets, the mobility. Now mobility is important in endodontic scenario because in certain acute alveolar abscess cases or any periradicular lesion, there's a accumulation of granulation tissue or fluid beneath the apical foramen, which can lead to grade 1 mobility. So you cannot just tell mobility is only related to perio, but in endodontics also, if the inflammation is beyond the apical foramen, you will be having these cases of mobility. Then comes the vitality, which is the most important part of examination. And if there is any swelling present, we have to examine the swelling. I can just tell you in short what to examine in swelling. In inspection, you have to see the extent of the swelling, the border of the swelling, size, shape, surface, the skin and mucosa over the swelling. Then you have to palpate the swelling for tenderness and local temperature. You can rule out the species involved in that. Okay. Srishti, yes, I'll explain you what vitality is because this is a very important part. I have covered it. Now comes the favorite part of Srishti, what she just asked me as a question. So vitality tests. Before going to vitality test, I want to explain you very easily what are the fibers that are involved in the vitality test. So vitality test can be sensibility test, can be oximetry test. We check about the oxygen saturation, and the sensibility test is sensing the neurons inside the tooth. So these fibers, the nerve fibers inside the tooth, are divided into A fibers and C fibers. The A fibers are further divided into beta and delta. We won't be going deep into beta because it's only mechanoreceptors, but delta and C fibers are majorly involved, in pulpal pain. So the difference between them is that A delta this is very short. I have made a table, but in Grossman you have a very detailed explanation of all those fibers in the chapter of dental anatomy and pulpal anatomy. You please go to that chapter. So A delta fibers is myelinated fibers. Myelinated means they're covered with a myelin sheath. So the transduction of the potential is very fast. The pain can be conducted in a very high speed, like 5 to 35 meter per second. But C fibers are unmyelinated. They're very slow. First of all, the distribution is very important. As you can see in the diagram, A delta fibers are, located in the odontoblastic zone of the pulp over this side, at the just junction of dentine and the pulp. They're distributed over here. Whereas C fibers are from this side to the middle region of the tooth. They are involved in a very deep pulpal core. And A delta fibers, it is associated with sharp, brief, and pricking pain, whereas C fibers are associated with dull, burning, aching, and prolonged pain. A delta fibers well localized, whereas C fibers are more diffuse. Now, this is very important, last point, that A delta fibers are elicited by mechanical and thermal stimuli, as well as C fibers are also. They are mainly elicited by chemical stimuli, persisting mechanical and thermal stimuli. So if you see A delta fibers now, in cases of reversible pulpitis or hypersensitivity, they respond very quickly to cold. They respond very quickly to cold, but they give a delayed response to the heat. Generally, reversible cases and sensitivity cases, they don't give any response to heat. They are majorly responsible for only A delta fibers. But if you come to C fibers now, if the pain or the pulpitis has prolonged to such extent that C fibers are involved, so the thermal test like heat test and cold test both are responsible to elicit a response in C fibers. Now, if you see the methods of tooth vitality assessment, it can be neural sensibility test, which consists of thermal test, heat test, and the cold test. Then comes the electric pulp test, anesthetic test cavity. Then we have pulp vascularity test. These are the new testing methods which are involved and still under study. They are incorporated in very corporative dental clinics where the budget is very high. But we cannot expect this in a government colleges because, and you have lots of patients. We cannot just do the pulp vascular test in every patient. So you have to go through this first method of neural sensitivity test. So the pulp vascularity tests are divided into pulse oximetry, laser Doppler flowmetry, and all the others that have been mentioned. But for us, as a third year and final year intern students, it's very important that you should know about neural sensibility test. And moreover, thermal tests are very important because you can routinely perform in your clinics and in your postings. Okay. So, once again. So these are the various chair side heat tests we can perform. It's very important to use electrical heat carrier. It's very safe to use because you have the temperature control. If you don't have this, so you can use hot gutta percha stick. You can use hot burnisher, hot water under rubber dam isolation, and hot impression compound. But these tests are not reliable. And one more tip I want to give you in a practical scenario in your college, like if you're having a patient and you have to do a heat test, so your seniors must be telling you कि burnisher को red hot तक लेके जाओ, फिर इसको दांत पे लगाओ. Can you imagine if the metal is turning into red hot? what will be the temperature of that particular burnisher. It will be so much that even if the patient is not having irreversible pulpitis, you will give him that irreversible pulpitis. It's so severe. So the temperature has to be maintained. Now, electrical heat carrier, okay, so you don't have it. But how will you do it if you don't have it? You can use hot 𝘱𝐻 stick. Now, 𝘱𝐻, the temperature given here is 65.5 degrees Celsius. I'll give you one more pro tip. That 𝘱𝐻 is of two forms, alpha form and beta form. What we use for obturation, it comes under beta form. And some 𝘱𝐻s, they have both the forms. The type of heat which you give, it can change the form from alpha to beta. So for heat testing in the teeth, you can take the 𝘱𝐻, you can take the burnisher, heat the burnisher and check. The moment the 𝘱𝐻 starts melting or deforming, that is the temperature which is reached to 65.5 degrees Celsius. This pro tip you can apply in your clinics or in your boosting to check how much you have to heat the burnisher. You can write this as a note. So for that you can use. Now if you see the mechanism of how it acts, is very important. The heat application should be not more than 5 seconds. It should be only 5 seconds. And first you have to start with the control tooth. That is the procedure. Now you have to apply it for 5 seconds. What will happen? Then the pulp will inflame, leads to vasodilation. Then it will increase the intrapulpal pressure. Then it can reduce the neural excitation threshold at a particular time. Then it can give you 3 types of response. If the patient is having immediate pain, excruciating pain, that you have just touched the 𝘱𝐻 stick or the electric heat carrier, and he's giving you a major response. And the response does not even goes off after you remove that stimulus. It stays there. It lingers for a particular amount of time. You can there and there suspect of irreversible pulpitis. Now, after applying for 5 seconds, it should get a delayed response. This is why, because first of all, when you apply the heat, the threshold will increase in A delta fibers, which does not respond to heat much. Then the temperature will flow down towards the C fibers. The moment it reaches the C fibers, it will give you a response. So this delayed response can tell you that the control tooth is normal, or the tooth in the picture is normal. That is a positive response. And when there is no response at all, you're applying it for more than 5 seconds, still there is no response, then you can suspect that the teeth is non-white. Or you can apply certain other kind of tests to rule out. Now this is the electrical heat carrier which can be used, and this is the 𝘱𝐻. This is not a usual 𝘱𝐻 that we use for obturation. It's a 𝘱𝐻 stick. The stick is being heated to 65 the moment when it starts melting, and you have to apply it on the tooth for 5 seconds. I hope you understand this heat testing part. If you want me to repeat, you can see in the chat box also once again. Srishti, samjha?
Yes, actually I wanted the definition of it, but I got an insight. Thank you.
Okay. Definitions you can check inside the book, because I'm not so prepared. I have given much more viva for the definitions in my college. Now I don't remember the definitions. Now comes the cold test. Now for the cold test, we have various materials. It can be endo ice, tetrafluoroethane, carbon dioxide snow, pencil of ice cold water under rubber emasculation, and ethyl chloride. Among this, endo ice is very, very best method of using cold test. It has a temperature of more than -71 degrees Celsius, I guess, and it can be applied on a cotton ball, and then you can apply it on the tooth. Then pencil of ice can be used in the government scenarios in which you can store it inside a distilled water inside the syringes and keep it for freezing, and use those pencil sticks to check the response. Then comes the electrical pulp test. Electrical pulp test is very important because it gives you a small electrical charge. Each tooth and each inside tooth also enamel, dentine, and pulp, they have particular response for the electrical conduction. So, there have been various studies that what is the threshold of electrical conduction inside the tooth, which can be read inside the books. They have different tests. So electrical pulp test can only tell if the pulp is vital or not. It won't say the oxygen saturation content or the flow of blood inside the pulp, and it is can elicit a response for calcified teeth. In the carious teeth, it can give you a false response. If you are using any crown restoration, also for that also it can give you a false response. There are more chances of false responses in electrical pulp test, but it is better than the heat test. If you see the accuracy given in the Grossman, heat test has an accuracy of 86%. Cold test has an accuracy of 86%. Electrical pulp test an accuracy of 81%, and heat test they have an accuracy of only 65 to 70%, not more than that. So to judge the teeth about its response, cold test and electrical pulp test is the best combination. Now you can see in this diagram, this is a setup of electrical pulp test. So this is a probe rheostat in a metal sheet. For incisors, it is applied on the incisal third, and for molars, it is applied on the middle third. Before that, you have to apply an electrolyte gel for the conduction of the electrical stimulus. Then you have to start with a very small amount of electrical charge. Then you have to keep on increasing. And the response what patient says is that he will feel tingling sensation, a warm sensation as soon as you increase the current. But if you see the response, they have given a table inside the Grossman. You have various responses. It can be a normal response, negative response, early response, delayed response, false positive, false negative. Just study that nicely. This is a setup for the newer methods that we talked about, pulse oximetry and laser Doppler flowmetry. This is a setup of pulse oximetry in which you can see. I don't think so. It is available in government colleges. So this particular has pulse oximeter which has two diodes. You can see here. It's applied over the tooth and a receptor end. So these diodes consist of light emitting diode, which simulates the red light, and then again one more light emitting diode which emitted the infrared lights. So these lights are passed from the diode towards the tooth structure, which goes inside the enamel, the dentine. The S shape of the dentine guides the light inside, and then it hits on the red blood cells. Those which have large amount of oxygen and concentration, they can give the reading inside the receptor, and then it is calculated, and the algorithm, it gives a difference of both the diodes and give you the oxygen saturation. So this is how you can say if the pulp is vital, if pulp is healthy or not. In the necrosis cases, you don't get any response in the pulse oximeter. And the second is the laser Doppler flowmetry, which runs over the Doppler frequency principle. That is a very big concept to discuss, and both of these are under development. So if you summarize in the clinical scenario during your posting, what all you can do is cold testing, heat testing, and electrical testing. As you can see in the cold testing, a mesh of ice is used and you put on the buccal surface of the molar. In the heat testing, 𝘚𝘱 can be used, and in the electrical pulp testing, electrical pulp rod can be used. So now this is the best combination and very ideal way of performing a pulp sensibility test, that a combination of cold test and the electrical pulp test. Now after that, if you move on, what if you have percussion test positive? How to rule out, without seeing further investigation, how to rule out whether the periapical lesion, what is the kind of lesion? The percussion here plays a very important role. If you are percussing the tooth and the patient is having pain, you can suspect of evident swelling underneath the apical foramen, or sometimes patient comes with a swelling inside his mouth. So there you can suspect that periapical lesion has been developed. So if the swelling is there, so it will give you an acute apical abscess. The swelling is not present, but still it is positive. It can suspect of apical periodontitis, the early lesion of periodicular diseases. Then after percussion, if there is no pain, that doesn't mean that the patient is not having the lesion. It may be that it has been there for several months and now it has totally gone up to extraoral lesions like sinus tract or extraoral swellings. So it can be like if the swelling is present with the sinus tract, can be a suspect of chronic apical abscess. If there is no sinus tract, only swelling with evident, flatulation inside the swelling, it can lead to asymptomatic apical periodontitis. Now, this is the scenario in which how does a sinus opening look like in the intraoral cavity, the periapical lesions. You can see there's a huge palatal swelling inside the tooth. It can be due to this incisor, can also be due to this canine also. So you cannot say this is a very large lesion with a sinus opening over here. Same goes with the first diagram. You can see the buccal aspect. We have a intraoral buccal sinus. The sinus is not open. It can be either due to premolar or molar. There's a method also to track the sinus. You can use a 𝘱𝑗𝑗 stick to inside this, the proximal spaces and can guide it towards the swelling and take a radiograph. As you can see here, this is a draining sinus. So they have used a 𝘱𝑗𝑗 stick and put it inside it to trace where the swelling is coming from. So they have seen in the radiograph that this particular lesion is from the distal root of this molar, already treated, acidity-treated molar. Now comes the aids what we can use for the diagnosis. Here is the radiographic investigation. Whenever a radiograph is given to you, is taken, you have to describe the IOPA in this particular format. You have to tell about the crown, how it is. Like now here you can see it is an ill-defined adolescency, involving the pulp chamber at all. The adolescency is going towards the root canals. Then you have to explain how many roots are there, what is the condition of pulp chamber, how is the condition of root canals. You can see obliterated here, can be calcified also. Then comes the lamina dura, medial space, periapical lesion, and alveolar bone. Now, if you see in this particular diagram, there's a huge cavity which is occupying the entire pulpal core almost. The pulp horns and everything has been covered inside this radiolucency. It's also going towards the root canals. And if you see here, there's slight pedial widening at the apical side. Here the lamina dura is little bit discontinuous. So it's an initial lesion of periapical apical periodontitis. I have some cases for you. In this, you can see it's an early lesion of symptomatic apical periodontitis, in which the lamina dura is completely vanished off. The pedial space is increased. There's a slight swelling in periapically. It can be due to the lesion present over here or constant trauma to the tooth. And in this case, you can see this has eventually turned into a granuloma. And in this tooth also, you can see there's a restoration already here. Maybe it's due to some seepage or leakage or faulty restoration. There can be a trauma to the periapical side, leading to periapical apical periodontitis. Radiograph plays a very vital role. So you have to judge the radiograph in all those points that I have shown you. The crown, the roots, the pulp chamber, the root canals, everything. So in this case, you can see there's a huge swelling in the first diagram, and it is getting traced by this 𝘱𝑗𝑗 stick. It can be a lesion of acute alveolar abscess. Here you can see this is the first diagram I showed you was the initial lesion of apical periodontitis, but here you can see it is progressing into severe one. The entire lamina dura is getting discontinuous. This is how you have to judge the radiograph and arrive at a diagnosis. Now I have made a sample case history for you. I was having a table also over there. So the patient came with a complaint of pain in lower right back region of jaw since 3-4 weeks. The HFAI was taken and this was published as patient was apparently all right 4 weeks back when he experienced pain which was spontaneous in onset, intermittent in duration, sharp and lancinating in nature, lunges for a period of time, aggravated having any hot and cold food or drink, nocturnal pain is evident, referred pain is evident, and it relieves by taking only medicines. He also gives a history of restoration at the same lesion 2 years back. Now, if you do dental examination, you saw the amalgam restoration with 4-6, secondary caries, lateral and vertical perfusion both are positive. Bite test is positive. Bite test can be done using a tooth sleuth, or you can keep a mirror inside and tell him to bite on the mirror slowly, increasing the force of bite. Then vitality test has given the response as painful response on application of endo eyes, and APT also shows an early response. So now there's a table you can make. With respect to 4-5, the cold has a normal response. With 4-7 also they have a normal response. Percussion is positive with 4-6. The cold response is immediate with 4-6. So this is how you can arrive at a diagnosis. The X-ray you can see there's a secondary caries beneath the restoration. It's approaching the pulp horn. You can see the PDL space is widened in the apical third of the root. It's progressing inside with PDL widening also. The mandibular is getting discontinuous. So these are all the symptoms of apical periodontitis, as you can counter it with the percussion method. So we can, for all these results, we can arrive to a diagnosis. Asymptomatic irreversible pulpitis with symptomatic apical periodontitis with respect to forceps. So this is how a short case history can look like. This is a sample case history. So after all this, you can go towards your treatment plan. Now, I have not covered treatment plan in majority as this was only a clinical case discussion and the method of taking a case history. But treatment plan is already divided into phases. I guess this diagram is a little bit towards the prosto aspect, but it's used in all the departments. They have divided into phases. First, you get a diagnosis, then you control the disease, then you restore the disease. Establish the functions again, and then you have to maintain it. So this was all about the case history. I hope you have learned something from me. This is my very own first lecture for you all. Thank you.
Thank you so much. Had a great time and found the lecture as illuminating as it was. If you have any questions, you can put it in the chat box so Dr. can answer it.
Okay. You can ask some questions if you want. I'll try to answer as per my knowledge.
I would like you all to switch on your cameras so you can take a screenshot.
Should I on my video?
Yes, sir. Please, could you?
Okay.
Please, everybody, switch on your cameras. Is the screenshot done, Bhumika?
Yeah, done.
Yeah. Thank you, everybody. Thank you.
Thank you so much for this opportunity. Clinical case. It's my first lecture. I hope it was good.
Yes, sir, it was great having you. It was an amazing lecture. Learned a lot.
Thank you.
Thank you so much. Thank you so much.
Good night.